Good afternoon, everybody, and welcome to Psychiatry Grand Rounds. My name is Tony Rothschild, and I'm the chair of the Grand Rounds Committee. Just a couple of brief announcements. In order to receive credit for attending today's Grand Rounds, please fill out the evaluation that came with the Grand Round announcements on Monday from Karen Lambert. Grand Rounds will be on Zoom for the rest of the academic year, but we are planning to do Grand Rounds in person in the fall, although it will always be available on Zoom for people who are too far away to come in person. A reminder, if you have questions for the speaker, please type them in the chat function. There is no Grand Rounds next week because of the resident retreat. The next Grand Rounds will be in 2 weeks on May 26th. And that will be the annual Deborah Jansen lecture, and it will be given by members of our faculty this year, Drs. Lorberg, Khadija, and Kostova. And the title of their talk is War in Ukraine, What are the Child Mental Health Perspectives? It's my pleasure to introduce Dr. Sheldon Benjamin, the Vice Chair for Education, who will tell us about today's named lecture, the Bruscoli Lecture, and then we'll also introduce today's speaker. Sheldon.
Thanks, Tony. Yeah, this is the annual Paul F. Bruscoli Memorial Lecture. And as the years go by, I think there are a shrinking number of faculty who remember Paul. I'm not sure if I may be the only one today that overlapped with him. Maybe Dr. Botsaris did. Paul was a member of our residency class that graduated in 1992. He took a job on 8 East, our inpatient psych unit, and immediately began doing psychodynamic psychotherapy supervision, which he kind of focused on during his residency. He was very, very popular, both as chief resident and also as a supervisor. Unfortunately, very shortly after he joined the faculty, he contracted AIDS and passed away at a time when it was much more common to not survive AIDS. His partner and his family and a number of faculty and friends here at UMass created a fund to endow this lectureship and eventually another event, the Paul F. Bruscoli Award for Faculty Resident Academic Collaboration, which nominations are open for right now for the best academic work product between a faculty member and a resident. Paul's lectureship alternates among topics that have to do with HIV, psychiatry, LGBTQ plus mental health, and psychodynamic psychotherapy. He was one of my psychopharm supervisees long ago, and so he would now be 65 years old. And hopefully still supervising had he lived. I'm gonna unshare the screen, I hope. And now I'm gonna introduce the speaker. So Dr. Erick Hung is professor of clinical psychiatry in the University of California, San Francisco Department of Psychiatry and Behavioral Sciences, member of their Academy of Medical Educators, and hot off the presses, I'm allowed, right, Eric? Yeah, hot off the presses, Dr. Hung is just transitioning from a decade as the residency program director at UCSF to the new associate dean for student affairs at UCSF. He is a forensic psychiatrist, did his medical school and psychiatry residency and fellowship at UCSF. He's a lifer there, it seems, and joined their faculty in 2009. But before moving to California, he completed his bachelor's degree right here in Amherst, Mass. at Amherst College. He actively teaches in risk assessment, medical education, forensic psychiatry, leadership, ethics. He's a member of the Psychiatry Training Directors Steering Committee, and we were just on a call a couple hours ago together about that. His interests, he's our treasurer, by the way. His interests include primary care and mental health integration, interface between mental health and the legal system, interprofessional collaboration, HIV, psychiatry, LGBTQ mental health, forensic psychiatry, medical education. He's the director of the LGBTQ Psychiatry Clinic at UCSF Health. This is an interdisciplinary partnership with the UCSF Gender Affirming Health Program and the UCSF Center for Sexual and Gender Minorities. He's gotten a lot of awards for his research and teaching. And in addition to all the publications and awards you find in his CV, There are 12 pages of mentees listed in his mentorship area, and 12 pages of formal teaching at his university, in addition to all his invited presentations elsewhere. And just my understanding is there's 40 child psychiatry faculty watching from Tower Hill Botanical Gardens from their annual retreat today, in addition to those you see online. And I'm delighted to introduce to you Dr. Erick Hung, this year's Bruscoli Memorial Lecturer. Erick?
Well, thank you so much for that warm introduction, Dr. Benjamin. I feel so incredibly honored to be able to be here for this particular Grand Round series and this particular lectureship. Dr. Bruscoli seems like just an incredible mentor and teacher and, you know, clinician and advocate and friend to the department. And so I feel very honored to be here on his behalf and with you all today. We are going to today talk about transgender and gender non-binary mental health. And I have really kind of thought about, you know, this important role that mental health clinicians, psychiatrists, psychologists, social workers, physicians play in the national landscape in thinking about how we advance transgender and gender non-binary mental health, and how we really need to think of ourselves not only as caregivers, but really also as allies and advocates. And so the talk today is really kind of thinking across this continuum. I don't have any disclosures for the talk, but I will share my perspective as Dr. Benjamin had articulated. I will share my perspective in directing our LGBTQ mental health clinic, which is part of one of many clinics in our gender affirming health program at UCSF. We provide lots of different services as part of that gender affirming health program, including primary care, surgical interventions, and then also much needed mental health services. And so the clinic that I oversee with our residents and with other faculty and staff is the kind of mental health component of the much larger gender affirming health program at the university. I want to start with a story. And I think that the story of so many individuals who identify as a gender minority is one of both trauma and resilience. And this story from a poet and artist, their name is Lee Makobi. They are from Cape Town, South Africa. I wanted to steal a couple of minutes to be able to share Lee's story that Lee shared in a TED Talk in 2015, because I think it so nicely and also poignantly captures the experience of this community, of our community. And I want to share that with you today as a way to start. Actually, before I do, I'm going to just double check one thing, which is to make sure that I'm optimizing this for video. Great.
The first time I uttered a prayer was in a glass-stained cathedral. I was kneeling long after the congregation was on its feet, dipped both hands into holy water, traced the Trinity across my chest, my tiny body drooping like a question mark all over the wooden pew. I asked Jesus to fix me. And when he did not answer, I befriended silence in the hopes that my sin would burn and salt, my mouth would dissolve like sugar on tongue, but shame lingered as an aftertaste. In an attempt to reintroduce me to sanctity, my mother told me of the miracle I was. said I could grow up to be anything I want, I decided to be a boy. It was cute. I had snapback, toothless grin, used skin knees as street cred, played hide and seek with what was left of my girl. I was it, the winner to a game the other kids couldn't play. I was the mystery of an anatomy, a question asked but not answered, tight roping between awkward boy and apologetic girl. And when I turned 12, the boy phase wasn't deemed cute anymore. It was met with nostalgic aunts who missed seeing my knees in the shadow of skirts, who reminded me that my kind of attitude would never bring a husband home, that I exist for heterosexual marriage and childbearing, and I swallowed their insults along with their slurs. Naturally, I did not come out of the closet. The kids at my school opened it without my permission, called me by a name I did not recognize, said lesbian, but I was more boy than girl, more Ken than Barbie. It had nothing to do with hating my body. I just love it enough to let it go. I treat it like a house, and when your house is falling apart, you do not evacuate. You make it comfortable enough to house all your insides. You make it pretty enough to invite guests over. You make the floorboards strong enough to stand on. My mother fears I have named myself after fading things, as she counts the echoes left behind by Maya Hall, Leela Alcon, Blake Brockington. She fears that I'll die without a whisper, that I will turn into what a shame conversations at the bus stop. She claims I've turned myself into a mausoleum, that I'm walking casket. News headlines has turned my identity into a spectacle. Bruce Jenner on everyone's lips, while the brutality of living in this body becomes an asterisk at the bottom of equality pages. No one ever thinks of us as human, because we are more ghost than flesh, because people fear that my gender expression is a trick, that it exists to be perverse, that it ensnares them without their consent, that my body is a feast for their eyes and hands, and once they have fed off my queer, they'll regurgitate all the parts they did not like. They'll put me back into the closet, hang me with all their other skeletons. I will be the best attraction. Can you see how easy it is to talk people into coffins, to misspell their names on gravestones, and people still wonder while there are boys rotting their girl away in high school hallways. They're afraid of becoming another hashtag in a second, afraid of classroom discussions becoming like Judgment Day. And now, oncoming traffic is embracing more transgender children than parents. I wonder how long it will be before the trans suicide notes start to feel redundant, before we realize that our bodies become lessons about sin way before we learn how to love them. Like God didn't save all this breath and mercy, like my blood is not the wine that washed over Jesus' feet. My prayers are now getting stuck in my throat. Maybe I am finally fixed. Maybe I just don't care. Maybe God finally listened to my prayers. Thank you.
And I want us to take a moment to reflect. What Lee shares, I think, is a powerful experience of one individual, but one that I think really captures the discrimination, the conflict, the resilience. And this is the community that we are taking care of. And we also live in a time where even taking care of this community has threats to those who are practicing in healthcare. You don't have to go very far to open up the New York Times to see another state banning our ability to care for patients in a humane and socially just way. Today, we're going to describe the relevant terms for taking care of transgender and gender non-binary people. I'd like to really have us walk away by being able to describe the major mental health disparities that face this community, to be able to understand how gender minority stress models can actually help us think about the kinds of interventions and levers that we need to advance healthcare, and for us to look specifically around the role of mental health professionals in providing gender affirmation, surgical evaluations, and our role in this process. And I think as we think about this, we see ourselves as caregivers and allies and advocates. And there are many different points within our healthcare system and the landscape in which we can intervene. So I'd like to start with a glossary of terms. And I start with the glossary of terms because as our clinic does ongoing education to clinics around us at UCSF and in other places, we are surrounded in a sea of terms that for many clinicians feels in some ways paralyzing. We want to say the right thing in the right moment. And yet we know that as we are trying to be as inclusive as possible, there is an increasing number of terms that we get caught up in, that we feel like it's difficult to know what is the right thing to say, what is the contemporary thing to say, what is the inclusive thing to say. And just even, for example, thinking about the glossary of terms in this particular spectrum from the masculine to the feminine, and then all the spaces in between, that sort of gender queer space in between. These are all terms that we can describe gender identity and gender queerness. And yet, as we start to try to wrestle with these terms and how they are similar and how they are different, I think it's important for us to educate ourselves and to be brave in thinking about how we can actually create more inclusive language, to know that we're not always going to be perfect, that we are going to misgender and may mispronoun, but to be brave and really trying to take that step forward to advance our vocabulary, because language is important. Language creates inclusion. And yet we also know that as healthcare professionals, we tend to want to be perfect, and we're not going to be perfect as we're trying to get better here. For those that are interested later, we have put together a really kind of nice glossary of terms for clinicians, and then also for learners and scholars. And we've put together a glossary of terms that I'll share later in the chat. I also think as we really kind of advance our language and conversation, that it's really important for us to distinguish between things that are really kind of fundamental, and yet I see these terms getting sort of conflated all the time. Differences between identity versus attraction versus behavior. It's really important for us to kind of be clear in our terminology, and for us to acknowledge that sometimes we kind of slip in the way that we describe these really important differences. And so I think that education is an important way to start. You all are fortunate in that you have a wonderful institute, the Fenway Institute, just right down the road, that has been probably the national leader in putting out essays, modules, education strategies to be able to help clinicians across this country be able to have more inclusive conversations with transgender and gender non-binary individuals. And for those that don't know the resources in the Fenway Institute, I encourage you to Google Fenway Institute, and you'll find a number of really important resources that you don't necessarily need to come to a Grand Rounds talk for. They are living asynchronously for everyone to be able to use. So let's talk a little bit about minority stress. And I use the minority stress model as a predominant framework in trying to really understand how we can intervene in the kinds of resources that we need to deploy in taking care of transgender and gender non-binary individuals. There are a variety of different minority stress models, I think, for us to include. And I think that I'll start with one that's probably not so dissimilar to the way that we already think about patients, using a biopsychosocial cultural framework. And that is really kind of the socio-ecological model of trying to understand communities and how individual factors, interpersonal factors in the environment, community factors, societal factors, how those can actually foster resiliency and also foster trauma. And for us to really think about this lens, I mean, you think about what is going on in Alabama or in Texas or in Florida right now, and those discriminatory practices that devalue the human being have significant impacts downstream in terms of how individuals think about relationships, how they think about themselves, and how they interact with the community and trust the community, including the community of healthcare providers. Minority stress models would also suggest that as we understand the role of stigma and the role of stigma in morbidity and mortality, that stigma as we know, creates cultures of harassment and abuse, of discriminatory practices, of violence, both interpersonal violence and structural violence. Those lead to communities feeling marginalized. Those lead to communities feeling that they don't have access to services, whether that is perceived or real. And that leads to behaviors that don't go treated by those services that we have, that then creates the morbidity and mortality that we are going to take a look at, particularly among transgender and gender non-binary individuals. And this minority stress model is not new. We have been thinking about minority stress for decades. I like to draw from the work of Elon Meyer, who sort of was predominantly kind of thinking about minority stress from the lesbian, gay, and bisexual lens, really thinking about it from the kind of sexual minority lens, but is an important lens, I think, to think about when we think about gender minorities, and thinking about how the environment itself, that kind of socio-ecological landscape, the discriminatory practices, the harassment, the policies that keep people from not having a voice at the table, how those environmental factors lead to two kinds of stresses. There are distal stresses and there are proximal stresses. Those distal stressors, which include prejudice, discrimination, violence, hit the individual, which then creates a whole range of proximal stressors that includes things like, for example, transphobia, concealment of identity, expectations that an individual is going to be rejected by the system in any, whether that's the school system, the healthcare system, and those lead to poor health outcomes, and specifically poor mental health outcomes. And now we also know that this model, which focuses, predominantly, in a kind of sort of disease-oriented or stress-oriented way, also can be adapted for resiliency, in that people's ability to connect to communities, that community connectedness can be a very strong factor that can actually reduce poor mental health outcomes. Pride in oneself can be an important mitigator for negative mental health outcomes, that this isn't all about a disease model, and that resiliency plays a very important part here. But this kind of minority stress model and collection, I think, is an important way for us to understand why there are significant healthcare disparities. And then, of course, you can't think about minority stress models without emphasizing, I think, the point of intersectionality, and that 1 + 1 = 7. And that as we think about helping patients navigate race and ethnicity and sexual and gender minoritization, that it is important for us to understand that these factors are all interconnected. And to really kind of sum up in sort of a big picture kind of way, I think that as we understand all of these kind of increased risk factors in the healthcare disparities that exist for transgender and gender non-binary individuals, it starts at the top with the dehumanization of this community and the anti-trans stigma that exists. That leads to denial of opportunity, whether that is real opportunity that is denied or the perception that opportunity is going to be denied. And that then later leads to increased risk factors and morbidity, mortality, and violence. And that is in some ways, I think, the cycle that we're trying to break. Whether we're doing it at the level of the individual or as advocates on a hill to be able to advocate for policies that are more just and more humane. Taking a little bit of a deeper dive in terms of the healthcare disparities, the Institute of Medicine really did, I think, a foundational kind of examination and exploration now 11 years ago, taking a look at the health of sexual and gender minorities. And in the Institute of Medicine report, I think a couple of really important disparities and differences rose, not just in terms of the physical health disparities from sexually transmitted infections, HIV and AIDS, certain kinds of cancers and hepato disease and cardiovascular disease, but also on the mental health side from suicide, depression, anxiety, smoking, substance use, harassment, bullying, victimization, violence, death. These are all substantial disparities that exist for gender minorities. And I think this particular Swedish cohort study, which came out at the same time as the Institute of Medicine report, really kind of sums it up in terms of looking at any cause of death for individuals who identify as a gender minority, that those curves that go downwards are not good. As you take a look at the curves for individuals who identify as a trans man or trans woman, and they weren't particularly looking at those spaces in between, but in taking a look at transgender individuals, those curves are going south really quickly. And it's this curve that we need to bend as a collective. I just want to kind of emphasize, I think, things that we see and read in the news all the time, and that we hear from our patients all the time, but just to actually put in some ways, staggering statistics behind them. When it comes to discrimination in employment, transgender and gender non-binary individuals are constantly facing discrimination in our public spaces, harassment, disrespect, physical assault, and that takes place in the healthcare setting, that takes place by police, that takes place in places where one goes out to shop and to eat. And there are very few states that actually ban employment discrimination on the basis of gender identity in this country. You take a look at disparities in legal identification and employment, and employment rates doubling for transgender and gender non-binary individuals, or individuals who don't even have the proper kinds of identification to be able to navigate all of the financial and employment and kind of legal services that are required, not even having the proper kind of identification to be able to do so. And then you take a look at our healthcare system itself, and individuals who identify as transgender and gender non-binary lacking health insurance, and that gap only increases as you think about Black and African American and Latinx communities. As you think about those who postpone care and those who are denied care, these disparities exist on a structural level in our healthcare systems, and these are the ways in which we actually contribute. And that contribution leads to a number of things. Now, you take a look at the study and you have different ranges, but you take a look at these statistics, and the statistics are staggering for transgender and gender non-binary individuals, in that 4 out of 10 individuals will have attempted suicide. Many individuals struggle with depression and anxiety, substance use disorders, and the rates of sexually transmitted infections, and particularly HIV and AIDS, is double, quadruple, and higher at times the general population. And these studies, I think, are reflected as well as we take a look at various mood disorders, anxiety disorders, substance use disorders. Again, this was the work of Elon Meyer now several decades ago. But the prevalence of mental health disorders, is orders of magnitude above our general populations that we take care of. And so it's really critical for us to understand these disparities and to create clinics and structures and avenues to be able to manage this effectively. And so to summarize the disparities in a nutshell, I'll let you kind of, in some ways, kind of absorb some of these statistics. I think the point that I want to make as we think about things like, for example, suicide attempts, assault by law enforcement, discrimination by employers, discrimination at the level of the school, inability to talk about these issues at the level of the school or with employers, and then the policies that continue to oppress. That these disparities are here because we have structures in place, both at the individual level and at the system level, that really continue these cycles of oppression. And it's our jobs as caregivers and allies and as individuals in this community to be able to disrupt these cycles of oppression. So let's talk about doing that. And I think that starts with gender affirming healthcare and gender affirming healthcare policies. So I think that the things that we do on a communication and interaction can be so important, and really trying to understand the incredible importance of pronouns and really appreciating the range of pronouns that individuals use and being comfortable with they, them. We have a hard time accepting that they, them is a singular pronoun. And we struggle with that in our language, and yet we know that that is so incredibly important, particularly for our gender non-binary individuals, and being able to really kind of affirm social transitions and social affirmations becomes important for us. It's also important to provide the right kinds of psychological services, not only access to counseling by trans competent mental health care clinicians. We know that we have a horrid history around conversion therapies, and it is important for us to be able to not only battle that, but to be able to provide trans competent mental health care and to really help individuals create a sense of authentic identity and a coherence in that as they struggle with how society accepts that identity. In thinking about the kinds of medical interventions that are gender affirming, they range from hormones and safe prescribing to helping individuals with reproductive options to being able to find trans competent primary care clinicians. We'll talk more specifically around gender affirming surgeries in that process, but also thinking about voice coaching, communication therapies, and really trying to follow some best practices and guidelines that these are all parts of the gender affirming healthcare system that we know we need to continue to build on. And we know that this is exactly that system that's under threat in a variety of states in which we may actually face not only sanctions, but criminal liability for being able to provide this kind of care that we know is gender affirming and reduces morbidity and mortality. And then finally, on the legal front, gender affirming healthcare looks like us getting active and participating in anti-discrimination legislation and supporting ways in which we can help individuals change their legal name and to expand the kinds of ways in which individuals identify gender on a variety of different sort of legal documents, and being able to ultimately get to a place where we have equal recognition under the law, an individual's right to autonomy and self-determination. So for those that feel like they're not as familiar with some of the kinds of medical interventions that we provide, just wanted to catch everyone up to speed. I won't spend a lot of time here, but for trans women, I'm really thinking about estradiol and spironolactone as interventions, and for trans men, testosterone, or otherwise shortcut as T. And then for adolescents and children, really thinking about the strategic use of pubertal blockers to really help think around gender affirming hormone treatments. And then when it comes to surgical treatments, really helping individuals who wish to have surgical interventions, not everyone does, but who wish to have surgical interventions, understand what those interventions can be and supporting them through this process. And we have a specific role in this process, and we'll talk about that shortly, but really helping individuals who want either feminizing surgeries. The top surgeries are kind of located on the left, and the bottom surgeries, kind of below the waist surgeries, are kind of located on the right. But really thinking about those feminization surgeries and masculinization surgeries that are really critical for those that want to pursue surgical interventions as ways of affirming their gender identity. And then last but not least, I think this kind of care really requires a continuum of care approach. We recognize that patients have a variety of ways in which they access healthcare services, whether that's in the private sector or the public sector, or using a variety of intensive case management services. And so as we think about the kinds of systems that we have in our local and regional areas, I've shared some of the resources that we have in San Francisco and San Francisco County. Those names are not important, but really thinking about how we build this continuum and really thinking strategically about what exists in the private and public sector, I think becomes really important, because we know that patients access care in a variety of different ways, and then it's often governed in terms of who can pay for it. And so it's important for us to kind of think very strategically around, do we have the kinds of resources that are needed in both of these sectors to provide the care that, that we want to create. Okay, so let me just share a little bit of kind of history with our field, and I'll kind of turn to the DSM as a way to acknowledge some of this history. And as we know, our field and our diagnostic understanding and our classification of disorders has evolved over the decades. I think that the importance when it comes to individuals who identify as transgender and gender non-binary is that the evolution away from this really being a disorder of the individual, and you kind of see that really reflected in the earlier versions of the DSM. In fact, the first kind of DSM that really kind of acknowledges this as an issue is in DSM-3 with the sort of diagnostic sort of category of transsexualism. And this kind of sort of acknowledgement that, is this really kind of a disorder at the level of the individual, or is this a disorder in some ways at the level of how this individual interacts in a society that is actually quite discriminatory and dehumanizing, I think is an important evolution that our field has made. And you can really kind of see this language evolve from even kind of using the terms as gender identity disorder was used in the DSM-4 to really thinking about this kind of concept of dysphoria, which is incredibly important in terms of thinking about kinds of services that we can wrap around, but really kind of helps to disentangle this being a problem intrinsically of the individual and really a problem of how this individual sort of navigates through a society that can be actually quite discriminatory. So I want to kind of emphasize that point because I think that we have made important steps forward here and we'll continue to evolve this language. Even the term dysphoria right now in many circles is debated. And I think that what's important for us to recognize is that there is this sort of complex kind of interplay of how individuals are really kind of navigating through our current society. So one thing that I'd like for us to particularly focus on, because mental health professionals are often specifically called upon in this process, is what I call the letter. And the letter is the mental health evaluation for individuals who are going through the affirmation process, particularly around surgical interventions. And I wanted to really kind of focus on this because I think this is an important way in which we can be clinicians, coaches, advocates, and also to help patients really kind of navigate a process that is incredibly important to them and that is incredibly, I think, important to be able to do well. What I'm going to kind of share is coming from the World Professional Association for Transgender Health, otherwise known as WPATH. WPATH releases standard of care, that's kind of the SOC, a standard of care for all healthcare clinicians, policymakers, but for the community to really think about, looking at the best available evidence to date, what kinds of recommendations can we put out there? The standard of care 7, which is our current version, is soon to be kind of ousted by standard of care 8, which is coming out in literally just a couple of months. It's not out yet. And that will kind of set forth a new kind of, I think, bar for different kinds of standards. But I want to kind of draw from where we are, because I do think that this very much relates to our role, particularly in the surgical affirmation process for individuals. People come to us in the surgical affirmation process being pretty distrustful of the healthcare system. A third of transgender individuals have delayed seeking care because of mistreatment. And 1 out of 5 individuals have been turned away by a healthcare provider previously. And so it is, I think, important for us to really take a trauma-informed care approach as we're taking care of individuals, because people are coming to us with a fair amount of distrust. And it is our job to be able to understand and work with that distrust if that exists. Now, when we think about our role in really being a part of this affirmation process, I think that there are kind of 2 sort of tensions at play. There is an informed consent model, which is, it is the job and responsibility of the healthcare provider to provide the information so that patients can make an appropriate informed consent based on their own wishes and choice. And that does not or should not be influenced by our wishes or choices. And that informed consent model, I think, is the predominant model today that we really kind of reflect on how we take care of patients and how mental health professionals kind of should play a role in this. But we do have some gatekeeper functions. And you'll see in the standards of care that there are some gatekeeping functions in which it is required to actually pass through mental health for a number of different kinds of interventions. And so we have this tension today in which we are kind of wrestling with the kind of tensions that exist between a gatekeeper and an informed consent model. And what that means for us as mental health professionals when we're involved in surgical evaluations is that at times we are playing the role as advocate, and at times we're playing the role of supporting individuals through this process. And also at times we're helping people sort of think about the right surgery at the right time, at the right moment, and really coaching them to be able to do that. And then we do have this evaluation role for insurance companies and also for surgeons. to be able to sort of say, yes, this person is appropriate, or no, this person is appropriate. And these roles aren't always aligned with each other, and they are sometimes in tension. And I think about this, of course, like coming from the lens of being a forensic psychiatrist, but I do think that it's important for us to recognize that when these roles are in conflict is often because it's not totally clear for us, are we playing the role of coach, or are we playing the role as an evaluator? And how do we kind of reconcile that? When we're asked to write surgical letters, we have a number of kind of elements that are important for us to kind of document as we support people through the affirmation process, and also make that evaluation. We have to be the ones to document whether there is well-documented persistent gender dysphoria. We have to be able to let surgeons know if an individual has the capacity for informed consent. And then I think that it's really important that for us to realize that if there are medical, or in our case, mental health concerns, that they be relatively well controlled through a process that can be somewhat stressful. And we know that the bar is different, say, for example, for top surgeries versus bottom surgeries. Top surgeries may only take, for example, a couple of days to recover, and some bottom surgeries, like an orchiectomy, may only take a couple of days to recover, in which mental health systems don't need to be all that well controlled if the recovery period is not that long. But if someone is going for a penectomy or vaginoplasty or metoidioplasty, where the recovery time may be 6, 8, 12 weeks, then we may want some relative stability in order to optimize post-surgical outcomes. And so we're really kind of thinking about this in terms of what the specific surgery is and what's the necessary psychosocial stability. And there isn't a diagnosis that should exclude someone like schizophrenia or borderline personality disorder, or at times even active substance use. Because we know that that for many individuals, being able to have an intervention, if it can be done in a safe and optimized way, can actually improve health outcomes. But we want to make sure that people can get there, and we can really optimize post-surgical recovery, and to make sure that the factors that may impact post-surgical recovery are addressed. So when we're taking a look at top surgery, we come into the mix because people need one letter. At least currently, they need one letter. We have to document gender dysphoria, we have to document capacity, and we have to document that medical and mental health conditions are well controlled. The bar gets a little bit higher for bottom surgeries, in which we require, at least now, 2 letters from licensed mental health professionals, the documentation of gender dysphoria, informed consent, conditions that are well controlled, and then also have some additional kind of conditions that really have been shown in the literature to really help optimize outcomes. And those conditions include, at least currently, 12 months of continuous hormone therapy if you're going for bottom surgery, and then 12 months of continuously living in the gender that's congruent with your gender role, if that has been safe to do so. These guidelines will change in Standard of Care 8. Most likely, we will be taking away the 2-letter requirement, which, if you can imagine trying to find 2 separate licensed mental health professionals that have some competence in this area, like mental health, is not easy to access for many of our patients. And so trying to kind of reduce some of the barriers that have been imposed by even some of the guidelines that we've created, and that will likely come out in Standard of Care 8. Okay. So I want to finish by just taking a look at some outcome studies, because I think that this is really important for us to recognize why it is important to have mental health professionals involved in this process, but not necessarily being gatekeeping in this process. I like this kind of work by Tim Vandergrift, who, of course, many of these amazing studies takes place in places outside of the US, but in the Netherlands, Dr. Vandergrift took a look at surgical satisfaction, quality of life, and the association of gender-affirming surgeries, and was really interested in the question of when individuals go for gender-affirming surgery, who is satisfied, who is not satisfied, who regrets the surgery, what kind of regrets are there, and is there a role for mental health in this process? And if so, what is that role? And really took a look at those questions in taking a look at the population, which included a fairly large group. It was over 100 trans men and trans women who were ultimately included in a study that took a look at these rates of satisfaction and were people satisfied or dissatisfied. And in the study, they took a look at 136 individuals specifically who had surgical interventions. Those interventions on the feminization side included vaginoplasty, breast augmentation, facial surgeries, and on the masculinization side included things like mastectomy, phalloplasty, metoidioplasty. And they were really interested in the question of, are people satisfied as they go through these surgeries? And the punchline is that, yes, people overall are quite satisfied with the surgery, even with modest complications in the surgery. And so if you take a look at the satisfaction data and those kind of percentages, which is that middle column sort of to the right, and you take a look at the complications, are high in some ways with vaginoplasty. They're high with vocal cord surgeries. They're high across a number of different surgeries, and yet satisfaction for the most part remains quite high. And Vandergrift was interested in, well, for those that are not satisfied, let's take a look at those individuals, and actually did kind of this kind of case sort of exploration with each of the individuals that were dissatisfied. Some individuals are dissatisfied because they had a poor outcome and a poor cosmetic outcome. But what was interesting is that there was no major regret for surgeries despite having various complications, meaning that the individual did not regret having the surgery and wanted to transition back to the sex assigned at birth. And I think that while dissatisfaction exists and it's rare, I think what's interesting is that it's really important to recognize that that sort of regret for having surgeries is not something that we commonly see, and yet that's something that's often kind of in our minds as we're helping patients navigate through this process. What can be helpful, I think, in helping to optimize dissatisfaction is that dissatisfaction tends to be associated with higher psychological symptom burden going into this process. So this particular sort of construct was measured by the SCL-90, which was taking a look at the total number of psychiatric and psychological symptoms of individuals going through the surgical affirmation process. And if individuals had higher symptom burden, then they were more likely to be dissatisfied. And similarly, if they kind of had a lower satisfaction in life, they were kind of more unhappy, then they had a higher likelihood of being dissatisfied. And this study suggests that it's really important for us to kind of optimize psychological symptom burden when individuals are going through this process. And that is the role of the mental health clinician. In addition to, it feels like sometimes people just rubber stamp these letters for surgical interventions, but it's really important for us to try to optimize psychological symptoms as people go through this process, because it will help with post-surgical outcomes and also help with dissatisfaction in this process by helping individuals understand what the outcomes can be and to be able to level set around expectations. Jack Turbin, recent resident graduate, has taken a look at a much larger population for individuals who have actually detransitioned in the United States. Detransition is a word that is now kind of fraught, and so we kind of like to kind of put it in quotes because the kind of even the word transition is somewhat outdated in terms of kind of the more contemporary term of affirmation. But Jack was very interested in the factors that lead individuals to detransition. And in this particular study that he did, which was taking a look at the US transgender data from 2015, out of the total respondents of individuals who had made some kind of a gender transition, those are 17,000 individuals, 2,000 of them had detransitioned, and Jack was interested in understanding, well, what were the factors that led to detransition? So taking a look at this sort of group of individuals who detransitioned, which is roughly around 2,000 individuals, they kind of categorized the factors leading to detransitioning into kind of two big buckets. There were external factors and there were internal factors. So external being sort of outside the control of the individual, internal being part of the individual's kind of psychology and sort of expectation setting. And I think what I'm trying to like emphasize in showing this study is that there are a lot of external factors that may lead individuals to detransition. So for example, if there is rejection from a spouse, discrimination from an employer, discrimination from seeking legal services, pressure from our healthcare system or individuals or society, that there are a lot of external factors for people to be aware of. And that's the role of the mental health professional in these kinds of surgical interventions, as we help people avoid detransitioning if that's the appropriate path for them, because we have to help them understand that these external factors don't necessarily go away after a surgical intervention, and for us to be able to create the support structures that people need around them. So these two studies I kind of in some ways draw to our attention, because it is important for us to actually not only rubber stamp these letters if we have developed clinics that are involved in writing these letters, but it is important for us to help patients navigate the right surgery at the right moment for them, and to be able to fully explore the kinds of external and internal factors that may contribute towards risk of detransitioning. And we should not be playing gatekeepers in this process, but we should also not be rubber stamping individuals through this process, because these are opportunities for us to actually intervene in a very important way. And Maddie Deutsch, who is our medical director in our gender affirming health program, really wrote a wonderful article that really talks about the framework needed for necessary psychosocial support and care navigation in the perioperative period, and to encourage us not to serve as mental health clinicians as just rubber stamping individuals through this process, but to actually have an important and substantial role, albeit one that's not necessarily a gatekeeping one. So I'd like to end by saying that this takes a village. This work requires a lot of us to do it. And that village includes a lot of community engagement and thinking about the continuum of care. This slide is all about San Francisco and San Francisco County, so none of this slide really kind of applies to you as a community. But what I would like to kind of highlight from this slide is that each one of these different resources reflects this. It reflects stakeholders in which we actually engage and listen to the community and have community partners that help guide our clinical systems, that we have appropriate housing resources, private and group practices, that we coordinate with the Department of Public Health, and that we have the kinds of legal services and academic health centers that can all sort of think about the continuum and engage in an important kind of way. And of course, we aren't doing this alone. There are a number of resources. This, for example, is a resource to identify a therapist who has competency in taking care of individuals who identify as a gender and sexual minority. This is a national kind of a portal to be able to find therapists. And this is just, one of many resources in which we're trying to really create a national collaborative. So resources for us to understand, there are a number of ways that we can really kind of educate ourselves and each other to be able to better take care of patients. And we have a number of really wonderful resources. And like I said, you have the Fenway Institute just down the road to be able to turn to. And with that, I'd like to actually just end by saying thank you. As a cisgender gay man sharing kind of the work that we've done in clinic, this is just one clinic and one perspective. But I do think that it's important for us to really think about how we take care of this community, how we take care of our community, and to really thank you for inviting me to this lectureship today, and to be able to honor Dr. Priscoli by sharing some of the work that we have done in clinic, and also tying it in with the work that's being done nationally and internationally. So thank you very much.
Thank you, Dr. Hung. It's obvious to all of us why you've won so many teaching awards. I hope I'm going to lob you an easy question here to get you started while people enter their questions in the chat, and then I'll pose them on their behalf. The timing of your lecture is particularly poignant. I'm sure it's occurred to you as well, as if the pandemic and the war in Ukraine and the imminent reversal of Roe weren't enough. This apparent direction, assisted by Congress, appears to be making discrimination against any non-majority person not only allowable, but even the law of the land in some states. This is undoubtedly going to lead to increased mental health problems at a time when we're not seeing any huge influx of new money into mental health care. So this is the easy part. What do you see happening in the next few years outside of California? Do all families with trans kids just move to California or the Northeast? Do you see causes for hope? That's my lob.
that is that is the question, right? Not the migration to California. No one wants to come to California. It's way too expensive. You know, yes, there's hope, but there's also, you know, we live in really difficult times, and I do think that it's important for us to really think through what it means to, you know, be in the spaces that we have the privilege of being, and the power that we hold in these spaces as healthcare clinicians, and for us to really amplify the voices of our patients to be able to foster the kinds of change that we need that may take decades. But we have, I think, important ways in which we need to actually share these stories so that we can actually foster change. And change takes time, and we actually take steps forward and we take steps back, as we're seeing right now in this national conversation. And we can't give up hope, because I think if we do, we aren't doing our patients justice and service. And so I do hold hope, even though it is hard to open up the news at times, and it is hard to be able to face, you know, your residents and trainees when like there's so much going on in the world and you're just trying to hold it together for yourself. But I do think that we as a community can do this as a community, and it's important for us to really speak up for people who have historically and currently not had voices and power and privilege to speak up and to be allies, but also to empower those that have been silent.
A very inspiring answer. Thanks. We obviously record the lecture, and the lecture will be available on our website, but someone also asked whether slides might be available. Are you open to sharing those, or would you rather not?
Whatever your preference, I'm totally open to sharing.
Looked like a keynote presentation, so it'd have to be a PDF probably.
It's, I'll give you the PDF. You know, for those, Dr. Benjamin is also the expert in PowerPoint keynote presentations. I've learned a lot from him over the years, and I've become a sort of a keynote enthusiast, and so this was a keynote presentation.
Yeah, well, so we'd appreciate the sharing. So, so one question that we have is, have you dealt with depression and anxiety related to hormones given to trans women, similar to problems that some people have with oral contraceptives?
It's a wonderful question, and we do counsel some individuals that they may experience mood symptoms after starting feminizing hormones, so particularly sort of estradiol and spironolactone, less so with spironolactone. We have, you know, I would say that for some individuals there are, but I think it's very much kind of overblown. And part of the reason that we have found that it's been overblown is that the direct kind of effects that one might see from estradiol, I think, are far overshadowed by thinking about the psychological effects that take place when someone actually is affirmed in the gender. And so that these kinds of differences that we see, we talk about the potential, but in most cases in our clinical practice, that just doesn't play out, that individuals going through hormone treatment feel a sense of authenticity and self that far overshadows, I think, some of the biologic effects that we sometimes fear that still contribute, but I think have a very much smaller effect size than we actually think that they do.
So the affirming treatment they're getting is a kind of antidepressant, it sounds like.
Yeah.
More or less.
Now, that's not to say that that doesn't exist, but I do think that the affirmation is quite powerful, and it's much more powerful than we sometimes give it credit for.
Have there been, this is my own curiosity, not from the masses here, but have you seen any serious psychiatric morbidity emerging from transition? You know, something on the level of psychotic symptoms or mood disorder with psychosis, that kind of thing?
We have not, and we have had individuals who, you know, we've had certainly individuals in which there have been sort of an exacerbation of symptoms, but I would say that that exacerbation had often sort of been tied to, you know, pre-existing conditions that were not particularly well treated at the time that they went through the surgical affirmation process, or to a certain extent the hormone affirmation process, but more on the surgical front is, I think, where most people are concerned. And it was actually not appropriately treating those conditions at the time of the surgery that led to bad surgical outcomes. And so For us, we kind of take this approach where it really depends on the surgery. And so, for example, I shared earlier that if someone is going for orchiectomy, in which the recovery period is going to be 2 to 3 days, it's an outpatient procedure, you don't have to have someone fully kind of teed up through that process in order to have a positive outcome. But if someone is going through a process, a surgical intervention that's going to take a long recovery time, and you're going to need someone to actually help with drainage and help take care of the psychosocial needs of recovery, then you want to really make sure that those symptoms, if they are there, are fully optimized by the time they hit surgery.
Okay, and there's a question here from Dr. Lundquist, who is an alumna faculty of ours who went to become training director out in the Midwest and still comes to Grand Rounds. So she asks, what are some relatively common reasons to ask a patient seeking gender affirming care to wait or not obtain care at all other than lack of psychiatric stability? What else comes up?
Yeah, I think it's a wonderful question. So I think that there's been a couple of sort of buckets that we kind of help people kind of think through. One is around, I would say, kind of the expectation setting of what the goals are for surgery and what the expectations are of what the surgery will provide in terms of the satisfaction and quality of life. And for some individuals, there is this kind of sort of desire that I'm going to just kind of go through this whole process, and there's a thinking that surgery is going to solve the dissatisfaction or the suffering that currently exists. And surgery may solve some of that, but it's not going to solve other parts. It's not going to solve the ways in which you feel dissatisfied in relationships at times, or it may not serve you well if you have a fair amount of sort of psychiatric symptom burden, and that's not going to magically get better by a surgical intervention. And so it's really helping patients navigate that expectation setting and trying to understand, what can surgery offer? What do we have to actually think about in terms of actually addressing some of these other factors that we as mental health professionals know are important, but to help patients kind of appropriately kind of scope expectations. So that's, I think, one really kind of important way in which we will say, right now may not be exactly the moment or the expectations that you have. Let's really kind of think that through. Now, we have to do that delicately because we can very quickly kind of put in our own bias into that conversation, but it's important for us to, I think, engage patients in terms of realistic expectation setting. And then I think that there are some patients, particularly when the surgical recovery time is going to be long, if they, so for example, have a high frequency of use pattern with methamphetamine, with opiates, that they have, for example, active manic symptoms or active psychotic symptoms, in which it's going to impact their ability to care for themselves or impact their ability to engage with others to take care for themselves during that post-operative recovery time, then it's important to actually say, maybe right now is not the appropriate moment. Let's optimize those services and then proceed for surgery at a moment in the future.
Okay, thank you very much. I'm also impressed by how much commonality there is between your approach to the pre-surgical patient and what we do in the neuropsychiatry clinic when somebody's going to have an elective temporal lobectomy, which is fairly dramatic, for epilepsy control. And we get into a lot of the same things. Okay, well, thank you very much for an incredibly organized and erudite lecture. I think we'll all remember it. And hopefully in person sometime, we'll be able to have you back. Thank you very much, and congratulations on your new position.
Thanks. Take care.